Welcome to the STARS program, seniors taking active roles in society. And now, here's your host, ANITA FINLEY.
Do you ever think about blood pressure? You know, what is blood pressure? And is it good if it's high, it's low? Well, we have an expert, Dr. HAL BENDIT, who is board certified in family medicine, and he's over there at Medical Center Affiliates. And we're glad that you're here with us today. And so tell us what we should know about high blood pressure, low blood pressure. Is it contagious? Is this hereditary? What is this?
Wow.
A lot of questions.
That's a big topic. So let me just answer it. We'll talk about hypertension, which is synonymous with high blood pressure. And there are different types of hypertension, but generically, there are a lot of people in this country that have hypertension, and it's untreated, and it's a big public health problem. Medicine changes all the time. I don't do things the same as I did 20 years ago. I don't do things the same as I did 10 years ago, and there's some things I'm doing this year that I wasn't doing last year because of changes in our knowledge base. And I've been doing this for over 30 years. The one thing I talk to people about in terms of hypertension is there's no question that having hypertension or high blood pressure puts you at risk for diseases of the small blood vessels in your brain, stroke, in your kidneys, kidney failure leading to dialysis, and the small blood vessels in your heart leading to congestive heart failure, and the large blood vessels in your heart leading to heart attack. And these are really not subjects that are open to discussion in the medical community. We've seen an avalanche of evidence dating back from the 1950s that have shown us that hypertension increases your risk for these issues. So this is the kind of conversation I have with a patient who I'm recommending starting blood pressure medicine, and they want to know, well, why do I need high blood pressure medicine? I'm feeling great. I'm not having chest pain. I'm not having shortness of breath. I don't wake up 8 times at night to go to the bathroom. And, it's always, I came to see Dr. Bendit, I'm feeling fine, and he gave me hypertension, diabetes, and high cholesterol. I mean, that's, that's the paradigm that typically happens when someone, has a health screening and we find things wrong with them. So I need to educate that patient. I need to say, okay, here's the deal. You need to be more worried about having hypertension than being on medication. Because years and years of studies have shown that it's not about the medication you're taking, it's not about the diet you're on, it's not about the amount of salt that you're eating or not eating. If you believe that putting a cranberry under your arm lowers your blood pressure, great. If your blood pressure goes down, you're at a lower risk. And there are national recommendations by the American Heart Association, by the federal government, by the National Heart, Lung, and Blood Institute about when the doctor should start treating hypertension, at what kind of numbers and areas, and what types of medicines we should be using in different clinical situations. But the bottom line is, if your blood pressure comes down to within normal range, you're not at increased risk of having those bad things happen to you versus having hypertension. And that is whether you're on medication or you're not. As a matter of fact, what I tell patients is that depending on what other problems you have, for instance, if you have diabetes, there's blood pressure medicine that will actually help your diabetes. If you have heart failure or coronary artery disease, there's blood pressure medicine that will actually help that too. So the bottom line is, being on medication long term puts you at a better place than having high blood pressure. Because people are concerned about side effects. Well, what is this medicine going to do for me? It's going to lower your risk. Bottom line, no question about it.
Wow. And you don't even work for the drug company.
No. I mean, now, don't get me wrong.
No.
I talk to patients about diet. I talk to patients about lifestyle modification. I generally don't start antihypertensive medication at the first office visit without having that discussion. okay? Because there are two people in the room that have to be convinced that they need medication, me and the patient, okay? So it's a process, especially with a new patient that I don't have a relationship with.
So what are you going to tell them before?
I tell them what I just told
I
you.
understand.
And I also explain to them that, I get a lot of questions that people ask similar questions. The next question I get is, well, how long do I have to take this medication? And that's a very good question. It's very, very common. The answer is medicines don't cure hypertension. They control it. So once you develop hypertension, you usually have it for the rest of your life, and you need to be on medication. Not that you become addicted to the medicine, because I get that a lot too. The medicine controls your hypertension. As long as your hypertension is controlled, you are not at higher risk for developing those bad things. And matter of fact, you're not at higher risk for developing those bad things than someone who is your age, who has your blood pressure, and who is not on medication. I mean, large, double-blinded, international studies have shown that. So that's what I tell people.
And so what are the kinds of things that you want to tell people, for our listeners to know if they are on high? Let's just go with numbers too. What is hypertension that you worry about, and what is middle, and then also tell us what people should be doing if they want to avoid it.
Good answer. The general advice is a low sodium diet. Stay active.
What does that mean? Stay active.
Get up off the couch.
Okay, but is there more than that?
No. Well, you want to. I mean, it depends on what age and what your physical capacity is. Moving is important. Any type of walking, running, swimming, playing sports. Depending on your age, once again, but any type of aerobic exercise is going to be good for your heart and your circulatory system.
Which is the reason that high blood pressure can happen if you're not doing that, right? No?
I think those are general. That's general good advice.
Okay.
But the bottom line is that 99+% of people develop hypertension for an unknown medical reason. We really don't know what is the cause of high blood pressure. We know how to intervene medically to lower the blood pressure, and once again, we know that lowers the risk. But it's called essential hypertension. We don't know why. In a small percentage of people, they have kidney disorder or they have an adrenal disorder that can be treated and fixed. But the vast majority of people, the cause of their hypertension is unknown, and it's genetic. If you've had two parents who are hypertensive, you're going to be at risk for developing hypertension at some point. I think I read a study a number of years ago where they looked at hypertension and pre-hypertension, and the statistic was 2/3 of the population of this country either are hypertensive or pre-hypertensive over the age of 55. And most of them are not treated to goal. So what's the number, you ask? That's kind of been in flux, and I think if you look at the studies, especially that have been out in the past year or so, the answer to that question depends. If you have kidney problems, that number is a little bit different. If you have had a stroke, that number is a little bit different. But in general, you want to see your top number below 140 and your bottom number below 90.
Mm-hmm.
In general. So, if you come to my office, and I had a patient today who was on blood pressure medicine, and their numbers were 148 over 86. I said, that number's
But they're already on blood pressure medicine.
Yeah, that number's a little bit higher than I'd like to see it, but I'm not going to make any change today because I know that I'm going to see them in a month or two, and I've seen their past blood pressures, and they've been generally okay. But the other fact that people need to consider is, and I get this question a lot, I'm on one blood pressure medicine. You're putting me now on a second. Is that because I'm becoming resistant to the first? My answer to that is no, not really. Studies have shown that as you get older, your blood pressure gets more difficult to treat. And that's also very common. It's actually more common than not. It's quite uncommon that I see a patient who I have on, a small dose of one medicine that I put them on at age 55, and 20 years later they're on the same dose and being controlled that one medication. That's not the usual course of events. Through all the different types of body types and individuals, I've had patients over the years that have been bodybuilders and runners, thin patients, morbidly obese patients. They have hypertension. And people say, the other thing people ask me, so if I lose 30 pounds, okay, can I come off this medication? My answer is, we'll see what your blood pressure is. I don't know. I've had lots of patients that have lost a lot of weight and they've been able to come off of blood pressure medicine. And I have some patients who, in the same situation, who haven't.
Well, I'm going to stop you there because, well, first of all, let me tell everybody, you're listening to Dr. HAL Bendit, BENDIT, who is he's board certified in family medicine. He's at Medical Center Affiliates. And I'll give you the website that you can go to see this great company. It's medcenterinc.com, or you can call 888-622-1225. But let's just keep going on with this. So when you say that if someone loses weight, what does that do to lower the blood pressure, if it does?
Well,
not as much strain on the heart and the vascular system?
Well, that would be the assumption. And it's, your body is a very, very complex mechanism. So you can really get caught up if you look at it just as a pump and a bunch of pipes, okay? Because the pipes are dynamic, they have muscles, they have hormones. The heart is a muscle that is under the influence of a lot of different things. And, once again, we don't know what causes hypertension in reality. And there are theories about sodium involvement and weight involvement in patients who are sedentary. And, I'm not suggesting that weight loss is a cure, because actually I'm suggesting that it might not be. It's all about the blood pressure. If I have a patient that says, Doc, I stopped that medicine the last time you saw me, and I've been standing on my head for the 15 minutes a day, every day since I've seen you.
Has it made a difference?
My answer would be, great. What's your blood pressure?
Right.
Okay, and if your blood pressure is normal, I'm a happy doctor. Okay, so it's all about the blood pressure. They've actually done studies looking at different types of medication. There are different classes of blood pressure medicine, and they're really in the average patient, it's not so much the medication that you're taking, one or the other. It's that your blood pressure is controlled. That's the tipping point in terms of risk. Us physicians, we're all about modifying our patients' risk, lowering their risk. And this is one of the places where primary care is, has its roots. I mean, this is what I do all day. I talk to patients about their blood pressure, the medications, why I'm suggesting this medicine or another, why I'm adding a third medication, because nobody wants to take medication. And they certainly don't want to take 2 or 3 medications, but some people need to.
And that's interesting that you say that. Why wouldn't one do it? Why was something else? Because it's bringing some other things into the picture. Is that why? That the one can't do?
Well, once again, in broad strokes, if you are on one medication, I would expect that one medication would bring your blood pressure numbers down by about 10 points. The second medication might bring it down another 10 points. Broad strokes. So it depends on, once again, how bad your hypertension is. There was a study a number of years ago that looked at, I think it was a couple of thousand patients, and instead of giving everybody the same medication, they gave patients 3 medications at the same dose across the spectrum, okay, in an additive fashion. And the endpoint was controlling blood pressure. And what they found was that a large percentage of people over the age of 55 required 2 or more medications to get their blood pressure to goal. And to goal means lowering your risk: heart attack, stroke, kidney failure.
Do you take any high blood pressure medication?
I'm lucky. I'm lucky.
Your family didn't have it in.
We have some high blood pressure in the family, but I am.
And you exercise a lot, and you eat properly.
I exercise. I try to eat well.
Okay.
I'm not.
But you're thin.
I'm not.
But you are thin.
I'm not. Yeah. I try to. I'm active because I see what happens. But I can't say that. I can't take credit for not needing blood pressure medicine because it's something that I do. I can take credit for not needing blood pressure medicine because my blood pressure is not high. And it's not like I have a low-stress job.
No, that's true. So,
but I watch it. If I needed, let me tell you, if my blood pressure were consistently over 140, 142, over 90, I would be on whatever medication it took to get that blood pressure down.
But there are 2 numbers there. So is a higher number more important, or is a lower number more important?
Another good question. See, you're a patient. That's great.
Right. I know the answer.
When I was in training, they used to teach us that the top number, the systolic number, wasn't as important as the bottom number, the diastolic number. As a matter of fact, they taught us that as you age, systolic hypertension, top number going up, was a normal thing, and that you should accept and be comfortable with a top number blood pressure which is 80 points higher than your patient's age. We now know through evidence-based medicine and many studies that that is not true. That having top number only hypertension, systolic hypertension, is just as significant as having diastolic hypertension. So that's why when you ask me about blood pressure numbers, I say 140 over 90 in broad strokes. When I talk to patients who I'm starting on medication, I tell them my goal, I have 3 goals in taking care of you. Number 1, keep it simple. If I give you a medication that you're going to need to take, or I'm going to tell you to take 4 or 5 times a day, what's going to happen? You're normal, you're human, chances are you're going to forget a dose or not be able to do that, right? So my goal is to keep it simple. I'm going to try and give you a medication that is a once-a-day medicine, okay? Number 2, it's got to work.
How long do you give a chance for it to work?
Depending on the medication, depending on the patient, depending on where we're, what blood pressure we start at. I usually, in broad strokes, see patients back in about a month. So when I put you on a medicine, it's got to work. And what work means is that your blood pressure has to come down into a range that you're not at high risk. And the last thing is you have to feel good, because it's impossible to give someone a medication to treat a problem that they have no symptoms for, okay, and then make them feel crummy.
Right.
Right.
That's right.
And, as a human being,
right.
as a patient myself sometimes, I totally understand that. So I tell my patients, if you're having a problem with this medicine, pick up the phone and call me. But those are my 3 goals in treating hypertension.
Okay, and do you make them take their blood pressure every day? Those things you buy at the store? I have one, and I use it.
I'm not a fan.
When I go to the doctor, though, it's always less than what this shows me.
Well, I'm not a fan. I'm not a fan of those machines.
Really?
And this is my own personal opinion, not to be, reflected by who's on any side of this microphone but me. I've just had many experiences where patients have said their blood pressure is normal or their blood pressure is high or whatever. And I said, yeah, bring in the machine. And they take their blood pressure with the machine, and I take the blood pressure using my ears and a stethoscope and a sphygmomanometer. and the numbers are vastly different. Vastly different.
Very
The
interesting.
majority
Are they
of the
better, less? They're probably less.
doesn't matter.
Oh, they're just
if it's
different.
bad data, it's bad data. So I tell patients that, if you go to a health fair, if you're somebody with a stethoscope, we can teach a family member, or stop by my office. I would rather you stop by the office 3 times a week and have me check your blood pressure, and after a month have a bunch of information, so myself, I can have comfort, and you can have comfort that we're doing the right thing, that you actually have high blood pressure.
This is really a fascinating subject. So the blood pressure is probably the first thing that when you have a patient, people always get their blood pressure checked, and that starts a lot of things, doesn't it?
It does. It's something that everyone should be screened for, and they are. I mean, I see patients all day, and this is what is the first thing on the sheet when they come in is their blood pressure, their weight, their heart rate. And when someone takes your blood pressure, I firmly believe it should not be with a machine. And I always ask that question. I went to another place. I'm not even going to say where, but I went to another place, and they told me my blood pressure was 210 over 110. So
you're
I
kidding.
came right over to your office.
Oh my God!
And I take their blood pressure with a real machine,
Yeah.
and it's 110 over 80.
Now, how does that happen?
Because those machines are not real accurate.
Like going to Publix. There's the other
well,
thing. People go sit there and they see it.
Publix is a great store, but
That's
I
not
wouldn't
right.
I wouldn't send a patient there to have their blood pressure
Exactly.
checked. So
Yeah, but they're
they have great tomatoes and
really great.
good.
And this may be off the blood pressure, and I wanted to make this show about it, but it seems like now lately, anytime someone winds up in the hospital or somewhere, they have AFib. Is this something they've always had, or it just happens? Or, I mean, that's all part of this, isn't it?
Well, having your organs don't like to be in a hypertensive environment, and bad things happen. So one of the most common things that happens as a result of long-standing hypertension is congestive heart failure. And one of the side effects or risks of congestive heart failure, as it affects the electrical structure of your heart, is atrial fibrillation. So are we diagnosing more AFib? I mean, people are getting older. They're maturing healthier. And there's more awareness of some of these things. And there's Holter monitors, there's other things that we didn't have many years ago. So that probably contributes to more picking up of atrial fibrillation. Atrial fibrillation is a major cause of stroke. So I mean, that's an issue that certainly should be addressed and not ignored.
So cardiologists have a whole new cycle of life, because actually cardiologists didn't get involved in a lot of these things now. Years ago.
Atrial fibrillation's been around for a while,
but
that's not new. I think
maybe what's new is the quick response and the shocking of the a lot of new kinds of things to do. Excuse me, there was never an electrophysiologist that I knew many years ago,
okay.
right?
No.
Now all of a sudden,
there are many other modalities that are available to address things like atrial fibrillation.
Right.
When I started in practice in the 80s, there was medications to slow your heart, and there was just this question about putting everybody on anticoagulation with atrial fibrillation. And now, there's more of a more different things available, different ways to treat and address atrial fibrillation. And some of them are blood pressure medicines, interestingly.
There are also medicines that when you cut yourself, you bleed very badly. I don't know if that's some of the medicine but that's a very serious thing. Someone just told me that they were having problems with their heart, and now they're on a medication, and boy, they bleed.
Yeah, they're well, as I said,
because it makes your blood thinner.
One of the issues with atrial
Right.
fibrillation is it puts you at increased risk for stroke. So there's actually a formula that is nationally accepted called the CHADS VASC score, VASC, that I use and cardiologists use to determine if you have atrial fibrillation, whether you should be on anticoagulation. And it's all about the risk for stroke. And it looks at things like, are you hypertensive? Have you had previous heart disease? Do you have diabetes? Okay, and those issues, you plug those answers into this thing that I have as an app on my phone, of course, and I can say, oh, your CHADS VASC score is 3. You have a high enough risk of having a stroke from atrial fibrillation than the risk of being anticoagulated. Yeah.
So much to know, but isn't it wonderful that you get to know Dr. Hal so well that you'll want to go to him because he is so sweet, he's so smart, and I would think anybody would be very lucky to go to you.
That's very nice.
Dr. Bandit. He's not a bandit, but it's Dr. Bandit. Bendit, excuse me. It's Dr. Bendit, isn't Bandit, but you can remember his name. Bendit. Board certified in family medicine, medical center affiliates. You can call their office to make an appointment at 888-622-1226, or you can go to their website at medcenterinc.com. But if you make the appointment with Dr. Bendit, because when you call there are other doctors. But it's a great organization.
Yes, thank you very much.
Yeah, it was wonderful. I learned so much from you. Thanks a lot.
Fabulous. Thank you for your time. Wonderful.